Jaundice. So according to this, the definition of jaundice is very important. So jaundice is a clinical condition. Okay, what is that? It is a yellowish discoloration of tissue resulting from deposition of bilirubin. Okay, so why bilirubin is deposited? Because we know that normal concentration of bilirubin in plasma, it ranges between 0.2 to 0.8 milligram per deciliter. Now jaundice is detected clinically only when the bilirubin level exceeds 2 milligram per deciliter. Okay, so it is clear that all hyperbilirubinemia is not the jaundice. Okay, so now along with the jaundice, you have to know some points about the bilirubin and the bile. So bile contains 97.6% of water and 2.4% of solids, and these solids actually it include the organic and inorganic substances. And the bile, other than this water, the solid substances, they are organic substance and inorganic. What are those organic substances? These are the bile salts, bile pigment, cholesterol, fatty acid, lecithin, mucin. And inorganic constituents means some ions like sodium, calcium, potassium, chloride and bicarbonate. Okay, so the composition of bile, especially it is important, and there is a difference between the gallbladder bile and the hepatic bile. That is also important, that you have to know, because in the gallbladder the bile becomes more concentrated. Okay, so you can see here the bile salt has become from 1.1 gram per deciliter to 6 gram per deciliter. Okay, so and other constituents there, they are also increased. Okay, but the protein content, it is very less, it becomes nil. And the bilirubin is also concentrated. Here you can see 0.04 per gram per deciliter in the hepatic bile, whereas in the gallbladder bile it is 0.3 gram per deciliter. So in the gallbladder the bile is mostly concentrated. So we know from the anatomy we know that the two right hepatic duct, right and left hepatic duct, they join to form the common bile duct, a common hepatic duct. This common hepatic duct, it joins with the cystic duct that is coming from gallbladder, and they will form the common bile duct. Now this common bile duct will combine with the pancreatic duct. On the right hand side you can see the picture, and it opens at the second part of the duodenum, that is the ampulla of water. Huh? Now in this way bile it is going to the second part of the duodenum. And what is the function of bile in the second part of the duodenum? That we all know that, because bile will help in the emulsification of fat and absorption of different fats and fat soluble vitamins. Okay, now this is about the how the cholesterol how actually the bile is synthesized. Okay, the primary bile acid, then the secondary bile acid. Okay, so primary bile acids, they are cholic acid and ketodeoxycholic acid. Secondary bile acids are there, lithocholic acid, and all these, how they are synthesized, this is also important for the crossing purpose. Okay, so from the cholesterol, how the primary bile acid is synthesized, okay, by cholesterol 7 alpha hydroxylase enzyme, and which is the rate limiting enzymes. Okay, now the primary bile acid, when they are acted upon by the gut flora, so they will be converted into secondary bile acids. It will be uh, incorporated in the bile. Okay, so in this way the synthesis of bile is important. Intracellular transport across hepatocyte is partly through the microtubules and partly by the cytosol transport proteins. Okay, bile acids are also synthesized in hepatocytes from cholesterol, and the rate limiting enzyme is also important. Okay, now come to the synthesis of bilirubin. That is very important. Okay, so from the previous slides we have seen the compositions of bile. So bile salt, bile pigments, cholesterol, like this. So bile salts, the part of synthesis of bile salts we came to know. Now the bile pigments, it includes the bilirubin. So how bilirubin is synthesized, you can see here from the lifespan of RBC is 120 days. After 120 days, heme and globin will be separated in reticuloendothelial system, that is in the spleen. Now from the heme portion, the iron will go out and it will join into the iron ferritin storage part, and remaining part it will be oxidized by heme oxygenase to form the biliverdin first, then biliverdin, by biliverdin reductase it will form the bilirubin. Okay, now these bilirubin, how it will be drained, okay, that is important, and that will give you the concept of jaundice, mechanism of formation of jaundice. So for your purpose, you should know what is the normal level of bilirubin. And jaundice, it is a clinical condition when there is yellowish discoloration, and we will call it due to hyperbilirubin. Yellowish discoloration can be due to the deposition of carotene as well. Okay, so yellowish discoloration of skin and mucous membrane and sclera due to hyperbilirubinemia, and this hyperbilirubinemia, it should clinically exceed the value of 2 milligram per deciliter. Okay, so then it is clinical jaundice. So every hyperbilirubinemia, you cannot call it a jaundice. Now the movement of bilirubin from the reticuloendothelial system, that is the blue part, this bilirubin is the unconjugated bilirubin. So it has to enter into the circulation. In the circulation, it will combine with the albumin. From where this albumin is secreted, you can see on the left hand side, we have in the liver we have the hepatocytes. Now the function of hepatocyte is to release the albumin. Albumin is released from the hepatocytes. Okay, this albumin will combine with the bilirubin to form the and it will make this unconjugated bilirubin, okay, to soluble, okay, so that by the portal vein and hepatic artery, it will go to the liver. On the left hand side, you can see in the liver and the hepatocytes, and on the sinusoidal part of the hepatocyte, here you can see a portion that a transporter is present that will take up the bilirubin and it will release the albumin. Okay, so unconjugated bilirubin, okay, it will come from the spleen, then it will combine with the albumin, it will be transported via blood to up to the hepatocytes, and on the sinusoidal border of the hepatocyte we have some transporter that will take up this unconjugated bilirubin. Okay, so we can say any defect that is affecting this pathway, that is bilirubin albumin conjugation, albumin combination, bilirubin uptake, all will cause increase in unconjugated bilirubin in our blood. Okay, so inside the hepatocyte, these bilirubin will undergo conjugation by UDP glucuronide transferase enzyme. So this enzyme will convert the unconjugated bilirubin to conjugated bilirubin. After this conjugation, you can see, so the hepatocytes have two sides. One is the sinusoidal face, another face is the canalicular face, that is facing the bile canaliculi. So on the canalicular side, we also have some transporters. Okay, in these transporters, you can see they will help to throw the conjugated bilirubin into the biliary canaliculi and the bile duct. Okay, so in the bile duct, you can see here then again the same story, that right and left hepatic duct, they will join to form the common hepatic duct. Then from the gallbladder, the cystic duct will come and it will join to form the common bile duct. Then it will combine with the pancreatic duct, and ultimately the second part of the duodenum it will enter. Okay, in the second part of duodenum, you know that with the help of the gut flora and other enzymes, this part of this bilirubin, conjugated bilirubin, will be converted to urobilinogen. Okay, but urobilinogen, what is the fate of it? You know that you have heard about the enterohepatic circulation. So this urobilinogen, it will be carried by the enterohepatic. You can see blood vessel is going back to the liver. Okay, so urobilinogen, it will enter into this blood vessel, and then it will again go to the main circulation, systemic circulation. Then it will be filtered by the kidney, and it will be excreted by the urine. Okay, so this is the part of the bilirubin that will be taken up by the intrahepatic circulation. Rest of it will be converted into sarcobilinogen, and that will go out through the feces. Now, sarcobilinogen is not the cause of yellowish color of usually the stool. It is a urochrome. Okay, that gives the yellowish color of the stool. So what is the fate? One fate is the urobilinogen that will enter into the enterohepatic circulation, and ultimately in the systemic circulation will be filtered by the kidney, and it will come out in the urine via urobilinogen. And rest by the starcobil, it will be converted to starcobilinogen. It will go out via feces. This is important. And we know that in case of newborn babies, this whole process of conjugation is not very well developed. That's why in some babies, in most of the babies, they initially develop some physiological jaundice. Okay, so just after birth, the bilirubin level becomes high until and unless this conjugation process becomes matured. Okay, this condition is normal, but if the level is more than 25 milligram per deciliter, then bilirubin level, then we have to give some therapy like this phototherapy. It is placed under some light of this kind, ultraviolet light. And what is the role of this light? It will convert this unconjugated bilirubin into a different isoform which is more soluble. So through the urine it can be passed out. Okay. Now come to the causes of jaundice. Okay, so I told you point number 1, point number 2, point number 3. One is that is release of bilirubin, excess bilirubin due to hemolysis. The unconjugated will raise the unconjugated bilirubin level. So hemolytic anemia, cause number 1, is it may cause the jaundice, that is the hemolytic jaundice, where the unconjugated bilirubin level is increased. Second point is that if the bilirubin cannot combine with the albumin, so it will not be transported to the hepatocyte and it will not be conjugated. So in that case also, the unconjugated bilirubin level will be high and the patient will suffer from unconjugated hyperbilirubinemia. Now, what are the causes where this is possible? There are certain drugs, for example, the sulfonamides, penicillin group of drugs that prevents the combination of this unconjugated bilirubin with the albumin. So, especially in case of newborn, okay, who are given these sulfonamide drugs or the penicillin derivatives, they may suffer from this type of jaundice. Okay. Now the third point, when there is a uptake of this unconjugated bilirubin by the sinusoidal phase of the hepatocyte. If there is any defect here, then also the unconjugated bilirubin level will be high. Okay, now there is a drug, anti-tubercular drug. This drug has a specialty because it causes the orange discoloration or pink discoloration of all secretions of the body. Even the ladies with their contact lens, it becomes pink in color because, okay, so very famous anti-tubercular drug rifampicin, they prevent the uptake of this unconjugated bilirubin by the hepatocytes. Okay, so the patient who is taking rifampicin, they are susceptible to develop unconjugated hyperbilirubinemia. So cause number 1, when the unconjugated bilirubin is produced in excess amount, that will cause unconjugated hyperbilirubinemia. Second point, the drugs that will displace the bilirubin from the albumin, that will also increase the unconjugated hyperbilirubin. Third point, when the uptake of bilirubin by the transporter, if it is not working properly, then also unconjugated bilirubin level will be high. So 1, 2, 3, they are the major causes of unconjugated hyperbilirubinemia. Second thing, fourth point is also important, that is when the conjugation process is defective, if the UDP glucuronide transferase enzyme is defective. Okay, so there is a genetic condition syndrome. For example, one is the Gilbert syndrome, where there will be mild deficiency of glucuronide transferase enzyme. So in that case, there will be unconjugated hyperbilirubinemia. Another syndrome is the Krigler-Nazer type 1 and type 2. So type 1 syndrome, that is a moderate deficiency of glucuronide transferase, and type 2, and type 1 is a severe deficiency of glucuronide transferase. This is a very fatal condition. So if the glucuronide transferase enzyme is defective, for example in Gilbert and Kriegler-Nadler syndrome, there will be chances of unconjugated hyperbilirubinemia also. And if there is some kind of hepatitis, okay, so hepatitis may be so many: viral hepatitis, it may be fungal hepatitis, toxins, alcoholic hepatitis, so many causes of hepatitis are there. Some are infectious, some are non-infectious. In that case also the conjugation procedure may be defective. Okay, hepatitis, but one point is important, not only cause the rise in unconjugated bilirubin, it will also cause some rise in the conjugated bilirubin as well. Why? Because that will prevent the release of there are inflammation, so this inflammation of the hepatocyte prevent the release of this conjugated hemoglobin bilirubin into the bile duct. Okay, so there will be cholestasis, intrahepatic cholestasis in case of hepatitis. So that is important. Now come to, so when the conjugation process is done, okay, this conjugated bilirubin level is released, okay, and if any defect happens after this process, there will be rise in the conjugated bilirubin level. So that is a conjugated hyperbilirubinemia, point number 5 and point number 6. Okay, so point number 5 is the intrahepatic causes, okay, of jaundice, obstruction of movement of bile. Now intrahepatic, and point number 6 is the extrahepatic causes mostly. So in case of intrahepatic conjugated bilirubin hyperbilirubinemia, two syndromes are also there. One is the Dubin-Johnson syndrome, another is the Rotor syndrome. So we have heard about 4 syndromes, genetic diseases related with the jaundice. Okay, so 2 will cause unconjugated rise in unconjugated bilirubin level. Those are Gilbert and Kriegler-Nadler, and we have heard about 2 another more syndrome that will raise the conjugated bilirubin level. That actually in these cases the movement of bilirubin or conjugated bilirubin through the hepatic duct, it becomes slower. So these are the Dubin-Johnson syndrome and the Rotor syndrome. And the specialty of Dubin-Johnson syndrome is that there will be discoloration, blackish discoloration of the liver. Okay, but these two syndrome, they are not that much fatal like the Kriegler-Nadler type 2. They are very benign. Okay, only the conjugated bilirubin level mildly will be high in the patient. In addition to that, there are certain drugs, for example, oral contraceptive drugs. Okay, and I think you have heard about it. Jaundice may happen in pregnant women as well. Okay, that is a gestational jaundice. Okay, or jaundice of pregnancy, because estrogen actually it prevents this movement of, it makes the movement of bilirubin through the biliary canaliculi slow. Okay, so female who are taking oral contraceptive drugs, they may suffer from this intrahepatic cholestasis because estrogen has a role to play here. Then we have the extrahepatic cholestasis, when the bile duct it is out of the liver, so there may be the gallstone, when there may be the pancreatic CA, there may be cancer at the head of the ampulla of Vater. So many causes of obstruction, and that will raise the conjugated bilirubin level. So I want to clear this concept that point number 1, 2, 3 and 4, where the excess production of unconjugated bilirubin, second, displacement of bilirubin with the albumin, third, uptake of unconjugated bilirubin is poor, and fourth, the conjugation process is very poor, defective. In these 4 cases, there will be rise in unconjugated bilirubin. Okay, it may be hemolytic jaundice, it may be drugs like sulfonamides or penicillin, it may be drugs like rifampicin, it may be syndromes like Gilbert or Kriegler-Nadler, it may be the hepatitis. Okay, in hepatitis, the conjugated bilirubin level will also be raised. Now, in case of what are the causes of conjugated hyperbilirubinemia? It may be some syndromes like Dubin-Johnson and Rotor. It may be due to the use of oral contraceptive pills, and it may be due to obstructions in the extrahepatic pathway. So many causes I have described. Now we have already completed it. So these are the causes, and clinically where actually we see the jaundice, that is very important. Upper bulbar conjunctiva, it contains elastin which has its affinity for bilirubin. So why on the upper bulbar conjunctiva? Because it contains elastin and it has the affinity for bilirubin. So on this you can see that how we are seeing the jaundice here on the upper bulbar conjunctiva. Okay, base of the tongue we also see, mucous membrane of palate, palm and soles, and general skin surface, and it should be seen in under daylight. Okay, now evaluation of jaundice patient. If we think about the jaundice, the patient is suffering from jaundice, then we have to go to the diagnosis, why the jaundice has happened. Jaundice is just a clinical manifestation. So it may be due to so many causes. It may be due to hepatitis, it may be due to cirrhosis, it may be due to alcoholism. Okay, so what is the cause of it, that we have to determine. Okay, by clinical examination we can do that. Okay, we have to check for the mental status of the subject, because in hepatic coma it will be lost. Okay, then in case of liver diseases, chronic liver disease. Okay, in case of chronic liver disease, there are some very important features of this. Okay, there, for example, there will be ascites, there will be dilated veins on the abdomen that indicates the portal hypertension. Due to the lack of albumin, there will be edema formation. Okay, there are some important xanthelasma, then the spider nevi, gynecomastia, because estrogen level will be high if estrogen is not metabolized, if the liver disease is there. All these features you have to look for. Okay, whether the patient is having this dilated veins on the abdomen, ascites is present or not. Okay, testicular atrophy, pigmented ulcers, all are the features of chronic liver disease. So you have to look for that. You have to see the liver size, you have to look for the edema, ascites, spider angiomata, then hyperpigmentation, xanthomas, gynecomastias. Okay, and left supraclavicular adenopathy, that is known as the Vico's node. Okay, all these features you have to look for. If you suspect jaundice, it is due to chronic liver disease. You have to take the history of taking medicines, what are the medicines the person is taking, alcoholic or not. All these history you have to take, and you have to look for all the features of this chronic liver disease. Now liver function test, you will ask the subject to do the liver function test. What we see in the liver function test, we see the albumin, we see the bilirubin, and we bilirubin, we see the total bilirubin, and the by direct method we see the conjugated bilirubin and unconjugated bilirubin. We also see the liver enzymes. For example, SGAT, SGPT, alkaline phosphatase, prothrombin time, because the vitamin K dependent factors, if they are deficient, so there will be chances of prolongation of prothrombin time. And some other GGT, alkaline phosphatase, serum aminotransferase, these are the in liver function test enzymes that we look for. That is also important for diagnosis of jaundice. Okay, so this is the algorithm by which we can detect the jaundice. You can see here the direct hyperbilirubinemia. So we have taken the history, what are the drugs the patient is taking, we have done the liver function test. Okay, now in the liver function test we have seen that the direct hyperbilirubinemia is there. Okay, so direct hyperbilirubinemia means the conjugated. So conjugated, you have to exclude, you know the causes, Dewey Johnson, Reuters, you know this gallstone is there. You have to ask for the USG, CT of abdomen, then any pancreatic carcinoma. So conjugated bilirubin it is okay. Now if it is indirect, okay, bilirubin level, only bilirubin level is changed, liver function test is not affected, then you have to look for the drugs like rifampicin, like Gilbert syndrome, hemolytic anemia or not. Okay, now if bilirubin is raised as well as the liver enzymes like AST, ALT, all these are raised, in that case or alkaline phosphatase, these are raised, in that case you have to look something else. So if the ALT AST level ratio it is elevated out of proportion to alkaline phosphatase, both are increased, but SGOT, SGPT or LTST is more elevated than the alkaline phosphatase, then think about the hepatitis. Okay. Now, if the alkaline phosphatase level is out of proportionally increased than the LTST, then think of cholestatic pattern. So, in intrahepatic cholestasis. So, it may be do an ultrasound, dilated ducts or extrahepatic, then CT, MRCP. Okay. So, all these tests will be done. Okay. So, if you suspect the viral hepatitis, then you can look for different other tests for it. Okay. If it is hepatitis B, the treatment protocol will be a bit different. uh, and all these hepatitis A, B, C, D, the route of transmission is different. Especially the A and D, they go through the oral, okay, food, water, like this. A and D, and B and C, they goes to intravenously. Some intravenous blood transfusion, even the sexually transmitted disease, they are transmitted sexually also. Okay, hepatitis B, hepatitis C. Okay, in HIV patients, you can see just like HIV. So this hepatitis B is also intravenously it goes, but sexually also transmitted. And these are the causes I have already discussed.